let me straight away go on to the subject that I'm given. The title of my talk is Miniaturization in PCNL. India does a lot of PCNL, and we started, at least I started doing my PCNLs from 1988 onwards. And of course, we had those standard PCNLs. Then the mini PCNL came in. And then in 2010, we thought about this still further miniaturization and called it Ultramini PCNL. So this is a short story on what is this Ultramini PCNL, the miniaturization in PCNL. This miniaturization of PCNL, I am very happy and proud to say that this story essentially came from India. We floated this idea in 2010-11. At that time, the idea of micro PCNL was also floated. And then subsequently, 3-4 years down the line, a few modifications came up. So essentially, this miniaturization came from India. That is what gives me a kind of some satisfaction and a bit of pride as well. I work in this city of Ahmedabad for people who are out of India, western part of India. And let me now begin this talk on the miniaturization of PCNL. Now, we all know that the story of PCNL began in the early 80s, I would say. Of course, the concept was floated by Fernstorm and the radiologists from Sweden, who actually, they could make a track into the kidney and gave this concept of removal of stone by forming a track from the loin into the kidney. And then standardized by Peter Alken, one of my heroes from Germany. And then at the same time, maybe just a little later, Arthur Smith and group, they started doing this in northern part of America, Minnesota. They started doing this PCNL where the dilation done at that time was 40-42 French, which is of course relegated to pages of history. Those are all basket cases now. And then we had those pneumatic device to begin with, the ultrasonic intracorporeal lithotripter to break the stones. So we could break the stones and with those small forceps bring them out. So from 40-42 French dilation, we settled, the urology community settled for a dilation of 30 French and what is called conventional PCNL, standard PCNL. And then in 2001, approximately, Sven Lamhe, he from Germany proposed this concept of mini PCNL. If you reduce the telescope, make special smaller size instrument, you can do PCNL the standard way, but the track becomes smaller. And they went on to say that the bleeding is less and you can remove most of the stones as effectively as the maxi PCNL. So mini PCNL is an option that you should consider. And then of course, the flexi URS came in, which is relatively non-invasive. So we have all these armamentarium. So where was the need of this Ultramini PCNL? And this talk is going to tell you the need of Ultramini PCNL. Well, I enjoy flashing this slide in majority of my talks. I go around wherever in the world. This equipment is a small equipment designed to destroy a small target. If the target is small, you have to use this equipment. But if you continue to use this large, massive, gigantic equipment, obviously there is going to be collateral damage. So this is, in my opinion, in a way I call it the standard or the conventional PCNL, which I now reserve for very large complex stones, tag-on stones. But for stones, mid-sized stones, small stones, this is the equipment, which is the UMP equipment. Now, if you compare the UMP sheet, if you compare the sheet, this is an 11 French sheet, and you can compare this with a 28 French plugs, which went over a 24 French dilator. So when we say that we do a 30 French dilation, you are not actually doing a 30 French dilation. You are doing a 35 French dilation. So when you pass that 30 French dilator, and then on that you slide the corresponding plugs, the ultimate effective dilation is 35 French. So when somebody says I do a standard PCNL, he is doing a 35 French dilation for his PCNL compared to a 11 French or a 13 French outer diameter dilation in the Ultramini PCNL. Now, as I said, the trend started somewhere. I floated this idea, gave this idea to Scholle in 2010. Scholle is this German company that makes the 3D camera and the laparoscope for the Da Vinci robot, based out of Germany near Freiburg. And they considered it. There was a little bit of brainstorming. They gave me the prototypes in 2011. We did some work on it in 2012. The final product came out, and we applied for C certification. Until you get the C certification, you can't sell the equipments. So that process was going on, and we produced our first paper, which was published in the British Journal of Urology in 2013. And our first video was presented on the podium in EAU Milan, where I presented a 10 minutes video in the podium session in that meeting, which happened in 2013 in Milan. It was gradually picking up momentum. And as a result, 2 or 3 years down the line, Stodds made the MIP, MIPX, Wolf made something called Perfect PCNL. Chinese companies made some modification. They added suction. We have the Indian companies making the miniaturized PCNL, where there is suction incorporated. So in short, all these companies or all the other colleagues who started doing and promoting miniaturized PCNL gave momentum to the gospel of miniaturization that I was preaching. And this whole concept was getting a huge momentum across Asia, then Europe. America was still doing standard PCNL. Very recently, we have introduced the Ultramini PCNL in America as well. So, keeping the rhetoric aside, what was the scientific backup? And we had a lot of papers published over the years, and let me take you through just a few of them. This was a paper presented by the German group, Thomas Knoll and group. Do patients benefit from miniaturized tubeless PCNL? A comparative prospective study. And they went on to say that yes, the technique is safe and effective for the management of renal calculi, and it had lesser hospitalization, lesser bleeding, and in short, a technique here to stay. This was published by Manoj Monga, who we all know was the secretary of the AUA and a very respected name in endourology. He published way back in 2000 in the Journal of Endourology that instead of using a 20 French sheath, or rather instead of using a 30 French sheath, if you reduce the dilation and use a 20 French sheath, the onslaught on parenchyma goes down by 56%. So instead of 30 French, in Ultramini, we use a 13 French or an 11 French outer diameter. So that much of reduction. Of course, we can't do large stones, we can't do complex stones, but we can do stones until 20, 22, up till 25 millimeters as well. This paper won a first prize. The title of the paper was Factors Affecting Blood Loss, and the most important factor was reducing the track size. One more paper, MiniPerk, what is its current status? And they conclude in the summary, hemorrhagic complications of mini-port are significantly less, making it an attractive procedure for treating renal stones. This was a paper published about a year ago, where experts from all around the world, from both sides of the continent, got together and published this percutaneous nephrolithotomy, update trends and future directions. And they go on to say that increasing miniaturization of equipment has led to the development of mini, micro, and ultra mini techniques. The tubeless method of PCNL is now accepted practice with good evidence of safety in appropriately selected patients. So we all know that PCNL is having a high efficacy and a higher stone-free rate, but we also know that it is invasive, it is associated sometimes with high morbidity. So how could we do it better? And we thought that we could do it better by this miniaturization techniques of PCNL. One of them is the Ultramini PCNL. We cannot solve our problems with the same thinking we used when we created them. This whole concept of the Ultramini PCNL came up from an observation. Just 2 days back, we had this wonderful talk by Patrick Walsh on Zoom. He was speaking from Baltimore, and this was organized by the University of Miami, the chairman of which is Dr. Deepan Parekh, one of our Indian urologists who went to US long back, and he has done exceedingly well. He's heading the huge department, and they had organized the meeting, and the title of the talk was listen to your patients if you want to discover. And this was something similar. All of us, we do our PCNLs, and we see that there is bleeding. We know that PCNL is very good in terms of stone-free rates, but if that bleeding part of PCNL can be taken away and the stone-free rate part can be maintained, I think it's a win-win situation. And when we were doing our PCNLs way back, I'm talking about when we started in 1988, and in the first 10 years, a lot of cases, the standard PCNL. So when we puncture and do the initial Teflon dilation 8 and then exchange by 12 or 14, and then you switch to the guide rod and then those larger dilators. Until that 14, 15 dilation, there was most of the times hardly any substantial bleeding. It was only when we increased the dilators, if we pulled out the 18 to be exchanged with 20 or 22, it was suddenly at that time we could see a gush of blood. And we tried to repeat this on, I was also heading the uro-oncology unit in Ahmedabad at the cancer hospital. So at that time, partial nephrectomies was not very popular. Even for a small tumor, we would remove the whole kidney. And if the tumor was, say, upper pole, I would then immediately, as the kidney was removed, try this dilation technique on the normal parenchyma. And we could see that initial 12, 14 dilation, the parenchyma would always remain quite intact. It was only when we went beyond 15, 16, sometimes there was a lateral tear. That part of the parenchyma, which was comparatively weaker, would give a little bit of a tear. And when we would do the procedure, there is torquing that would add little more to the tear and the bleeding. And the bleeding leads to clot formation, which obviously we would like to avoid. So we put a nephrostomy, and we all know that the pain is mainly because of the nephrostomy, not because of the track. If you do a 28 French dilation and don't put a nephrostomy, those patients will have lesser bleeding. Then you do a 22 French dilation and put a nephrostomy, which prompted Guido Giusti from Milan to produce that paper, Mini PCNL, no thank you. But he changed his views. If you ask him now, he says yes, it was a different setting. And now he's very much doing this miniaturized PCNL also. So this concept that If you reduce the dilation to less than 15, less than 14, there is a good chance that you will prevent the bleeding component, the bleeding part of the PCNL, and yet manage to break the stone. And this would be good enough for the mid-sized stones up until roughly 20 millimeters. With experience, you can do up to 25 millimeters as well. Now, if I give you an idea, 30 French will incorporate uh, area of 81 square millimeters. If you go down from 30 to 11, you go down 3 times, the area incorporated goes down almost 8 times. It becomes 10.5 square millimeters. And that's not all about when you do a standard PCNL, because when you do a 30 French dilation, you slide the amplats over it, which is 35 French. You try that out. You take the French scale. I'll show you on the video as well. So then it is 106.8 square millimeters versus 10.5 square millimeters. So it is substantially substantial reduction on the onslaught on parenchyma. So this is the 30 French Cook dilator, and this is the corresponding amplats which does not go in the 34 French hole of this French scale. And look at this video. Look at this video. So this is the 30 French Cook dilator, the corresponding amplats. I'm removing the amplats. So we check the dilator first on the French scale. This is the 30 French hole. And this dilator very snugly goes into the 30 French hole. Very, very precisely, no space left, but it goes easily because it's a 30 French outer diameter. The corresponding amplats, I'm trying to push through the 34 French hole. It does not go through the 30 French hole. It is 35 French. It is 35 French outer diameter. So therefore, I keep telling my American friends that when you say you dilate, you do a standard PCNL of 30 French, actually you are doing a PCNL of 35 French dilation. Let me compare the track. Let me compare the track of a 28 French dilation. This was, this is, this I can't play. So let me skip this. I was just trying to give you a comparison of the track. A nice PCNL was done here. There was hardly any bleeding as the PCNL was done, a good puncture, a good dilation. And then I'm withdrawing my telescope through the track. And the same thing I'm withdrawing when I'm doing this Ultramini PCNL and trying to compare the track. And the video clearly shows that despite a good puncture, when you withdraw, there is tear of the muscles outside the para through the muscles which are hit by the track. There is a fair amount of disruption in the pararenal tissues. There is bleeding going on, therefore the need of nephrostomy. And in this Ultramini PCNL track, there is a clean, neat hole punched in the fascia of Gerota, hardly any bleeding, and the muscles there is a neat hole, they heal well, you don't need a nephrostomy, patient goes home. In some parts of the world, they even do it as a day care procedure. They send the patient home the same evening. It all depends upon the dynamics of reimbursement. We in India have to keep the patients for 24 hours for Mediclaim reimbursements. Patients go home the next day, and sending them next day is always a good idea. You need to give them antibiotics, painkillers. So in the hospital, all those things can be done very effectively. You cannot discover new oceans unless you have the courage to lose sight of the shore. So we have to, over the years, patients have taught us that they are uncomfortable when we do the standard PCNL. Sometimes there is massive bleeding. There are different series coming out from different parts of the world. 2% to even, I read a paper where they said 14% of the patients needed blood transfusion, which is quite high. But bleeding has always been a concern for all the endourologists and even experts. Even people who have done more than 1,000, 2,000 PCNLs on a bad day, they do encounter bleeding, which is sometimes substantial. So, you have to think afresh. You have to lose sight of the shore, which means lose sight of those standard PCNL and try new things, which is ultimately how mini PCNL came in and how miniaturized PCNL came into existence. Invasiveness should be tailored according to stone complexity. And science does not move ahead in long leaps. It moves in small incremental steps, and miniaturized PCNL is one such miniaturized step, but a sure step. What happened?
So, any issue?
I can't move the next slide.
Can you just press escape and then come back again to screen to the
Yes,
slideshow mode?
I pressed escape. It seems to have frozen. I can't. Should I press stop sharing and then again come live?
Yeah, you can do that, sir.
I'm stopping to share.
Screen share, yeah.
And then I go back.
Can you escape the? No, yeah. Now you go back to the PowerPoint and
Share screen again.
yes, sir.
Yeah. Okay. Yeah. Sorry about this. So in continuation again, technology has brought us to this level. I mean, we could have done nothing if the different kind of technology had not supported us. So just to give you an idea that in 1956, look at this hard drive, a 5 MB hard drive being pushed by two strong men, pulled by another two strong men. And this 5 MB hard drive is having data 1,600 times lesser than the data stored in this 8 GB sleek little instrument, which has come just 40 years down the road. You can see how technology has moved. Look at the world's first camera and what we have today. Look at the world's first mobile phone and what we have today. So technology is helping us. This miniaturization is there essentially because we have the laser technology. A very thin 200 micron fiber can produce that energy, which can go through a flexible conduit and can hit a hard stone, a monohydrate stone, and can pulverize it. We have those fine optics in Ultramini PCNL. The telescope is just 1 millimeter, 3.5 French, which has a resolution of 17,000 pixels, which can be autoclaved, and it gives you a good vision of the pelvic calyceal system. So this technology has helped us to come to this level, and maybe down the road, we may have still further advancement in technology, and we can be more efficacious in the use of miniaturization, the nanotechnology, which is taking over in different aspects of our lives. Let me run a video of the Ultramini PCNL. This is a short video which will take you through the steps of the Ultramini PCNL. A patient we do in prone position mainly. Lately we have started in supine as well, but we are still proponents of prone position. A small incision in the loin, 4 to 5 millimeters, a standard puncture. There is nothing new here. A standard puncture, sonography guided or fluoroscopy guided. Once you are in the pelvic calyceal system, the contrast trickles out. You put in your guide wire under fluoroscopy guidance. The guide wire is well in position, part well. If you are lucky, it goes down the ureter, or it coils well into the pelvic calyceal system. You do a dilation. You can do a 8 French to be exchanged by a 12 French dilator. So the dilation is the initial Teflon dilators only, and then we slide either the 11 French or the 13 French UMP outer sheath. Yes, and then I have Nitin Gadgil calling me. I don't know. Should I take his call? He's hello. Yeah. So anyway, so this is the UMP sheath. This is the UMP inner sheath, which has one port, which is the irrigation channel, and hello, hello, hello.
So we are getting your audio.
Yeah, Nitin Gadgil was calling me. So do I need to respond, or you can talk to
No,
him?
he can, if any urgent, I don't know. He's not asked anything in the Facebook stream. So.
Ready. It is. I'm talking. I'm in the midst of it. Yeah, sorry about that. I thought that he's going to guide me on this.
No
Anyway,
issues.
so sorry about this. So this is the inner sheath, which has an irrigation channel, another port for the laser, which can take up till 365 micron laser fiber if you are using the 13 French outer sheath. And this is the telescope which has gone in the inner sheath. And sorry. So this is the outer sheath with the port which connects to a small tube inside, which will be useful to create that whirlpool. And I'll show you how we create that whirlpool. This is again repetition, the inner sheath, irrigation channel, laser channel, telescope. And now I'm putting the inner sheath with the telescope mounted in it through the outer sheath. You can see the pelvic calyceal system with the stone inside and with the laser. You can use anywhere between 200 microns to 365 microns, and the laser setting should be not dusting mode, but I'd say 10 frequency and 1.2 energy. So we are interested in making fragments, and at the end create this whirlpool, and all the fragments come out. We push saline by a small tubing connected to the side port. This is the side port. This one is the side port, and you push saline through a 20 cc syringe, and all the fragments inside, they are caught up in the whirlpool and they start coming out. So you can either put a suction or you can do this. The ultimate idea is to bring the fragments out without the use of baskets or forceps. So this is a picture captured from within. This is a flexible ureteroscopy capturing the whirlpool. This is how the whirlpool is created. They all get caught up in that vortex, all the fragments, and are moving from the high pressure zone to the sheath itself, and they are coming out. And these are the fragments which finally were brought out in different cases. So this is the Ultramini PCNL. And finally, the system is made stone free. You remove the outer sheath. We put a guide wire, wait for 2-3 minutes. If there is no bleeding, we just pull out the outer sheath. So it's a totally tubeless procedure. No nephrostomy, no double J stent. The patient can go home, as we said, late evening or next day morning. Of course, once in a while, you do encounter some bleeding. In that case, we put in a 10 to 15% cases, we put in a feeding tube, an 8 or a 10 French feeding tube, a soft feeding tube as a nephrostomy for about 12 to 14 hours. But we don't put a double J stent because at the end of the procedure, there is an argument which some people might do. What if the fragments have gone down the ureter? You pull the ureteric catheter a little bit down up till the upper ureter and push saline. Those fragments, they come back into the pelvic calyceal system and they come out from the outer sheath. So that is how we make this procedure a totally tubeless procedure. We have now the use of this latest kid on the block, the Trilogy by EMS, which is a combination of pneumatic, the mechanical energy with ultrasonic energy with ultrasound in a single probe. And the probes are available, the size of which is 1.4 millimeter, 1.9 millimeter, 3.2 and 3.9 millimeter. So the 1.9 millimeter probe can help you do the Ultramini PCNL also, of course, with a little bit of a different design. And once again, this media is not picking up. So anyway, what we are trying to show is we can break the stone by this Trilogy device. The mechanical energy breaks the stone, the ultrasonic energy makes it into finer sand, and the suction pulls it out. And this is a little modification of Ultramini PCNL. We are working on this prototype, not yet in the market, but there is a possibility that you can use this Trilogy as well for the Ultramini PCNL. Now, let me compare all this data of Ultramini PCNL, which I already gave you, with a little bit of data coming from the experts who have been doing the RIRS, the flexiureteroscopy. And this is one paper published by the EDGE group. We all know that this EDGE group is a consortium formed by a few universities in North America, Benchu from Canada, and there is this guy, Amy Krembeck, we all know from, I think, northern part of America. I forget the name of the university, but there is this Bodo Knudsen. And so all of them, they got together and they published this. And what are they saying? That flexiureteroscopy, the outcome stone event rate was 44%. So if you analyze flexiureteroscopy, 44% patients, they have some or the other stone event rate, either colic from residual stones, which will force them to bounce back to the OPD, or there is infection, septicemia in some instances. The stone-free rates are not very encouraging, and so very quickly, within 6 months or 8 months, they are back with a new stone formation, or maybe that same stone fragment started growing in size. So the stone event rate was 44%. And there was this editorial published by Peggy Pearl, who is the Secretary General of the Endourology Society, a very respected name in urology, endourology in particular. She wrote this editorial, and she said that closer scrutiny of URS using computerized tomography to ascertain stone clearance has yielded disappointing results. And she concludes the editorial by saying that the question is not, can we treat all patients ureteroscopically, but should we, and how can we do it better? So we all know that it is a relatively non-invasive technique, but it has its own share of problems. If you do the procedure for a longer time, I would say that 40-45 minutes, maximum 1 hour. Beyond that, the possibility of infection rises. If you pick up large stones, the stone-free rates are not very encouraging. Some parts of the world, they do staged ureteroscopy. Very difficult in our part of the world, in the Asian circuit, to call the patient again for a second sitting of flexiureteroscopy, and then you put a double J stent. So the patient actually comes in for the third time for removal of the double J stent. And if you pre-stent the patient to make the ureter more compliant for the passage of your ureteroscope and the access sheet, it becomes multiple entries of the patient in the operating theater, which the patient may not accept. And of course, the financial dynamics also are not going to allow us to use flexiureteroscopy 2 or 3 times in our patients. It is not what you don't know that gets you into trouble. It's what you know for sure that just ain't so. So, you know, you feel and you know for sure in flexiureteroscopy that it is non-invasive and everything is hunky-dory about it. But actually, there are problems associated with flexiureteroscopy as well. And it is in that subset of patients, the miniaturized PCNL steps in. It cannot replace standard PCNL for large stones, Mini PCNL also can tackle large stones and even staghorn stones. So the miniaturized PCNL is for stones between 12 and 20 millimeters. Flexiureteroscopy is for stones between 10 and 14 millimeters. And below 10, there is the good old ESWL, which I still believe, as a urologist, each one of us would put our hand on our heart and say, if I have a stone of 9 millimeters, what will I do? I will do lithotripsy for myself. So lithotripsy is still there for stones up till 10 millimeters. So this is the algorithm, which I'll show you at the end. Now, because of this stone-free rates, to bring out the stones is a difficult proposition. This idea was floated by Olivier Traxer, one of the leading authorities on flexiureteroscopy across the globe. And this is his slide, that if you break a stone of 2 centimeters into equal parts, you produce 8 fragments of 1 cubic millimeter. And if you break them into equal parts, you produce 64 fragments of 5 millimeter cubes, which itself are large stones. And therefore, to bring them out one by one is a very difficult proposition. So it is not a good idea to fragment the stones, but just dust the stones. And then we come to the laser setting, that for dusting, you need high frequency and low energy. And all we know all about this. But to dust a stone of 15 millimeters, I think you will need easily more than an hour, up till 1.5 hours. And if the stone is calcium monohydrate, no matter what you do, you will end up throwing a few chips of 1.5 millimeters. You cannot produce that fine dust. And in our part of the world, a large majority of our stone are calcium monohydrate. And in those patients, to produce complete dusting is not a very easy proposition. So there will be a few fragments which will be left behind and subsequently create issues about colic coming up, infection coming up, recurrence of stones coming up faster, etc. In our part of the world, again, Asian people, where the body habitus is slightly smaller than the Western world, you just can't put any excess sheath in roughly 8% patients. A 9.5 to 11.5, that is the smallest available in the market, goes in 52% of the patients. And 12-14 will go in 40% of the patients. You need at least a 12-14 if you want to remove the fragments. If you want to use baskets and remove the fragments, it is not very easy to use baskets in this small sheath, because it will get obstructed. The basket can get stuck up there, and not a good idea. You will have to then remove the basket, dismantle it, or cut the basket, and then put a laser, break the stone within the basket. It becomes very cumbersome. Now, 12 to 14 is a large sized excess sheath. We all started doing flexiureteroscopy by using a 14 French ureteroscope. If you remember those good old days when we did not have fiber optics, the ureteroscopes also had those rod lengths, and it started with more than 16, but then settled with 14. I have used a 14 French ureteroscope, and then fiber optics came in, and the first fiber optic ureteroscope was 12.5 French, which was considered very small. And then the urology community felt that showing that up the ureter was not a good proposition. So then came the 9.5, and then 6, and now we have the small needle scopes, as we call them. So the story of ureteroscope started with, say, 14, 16, and went down to 4.5. And we are now reversing the story by going back to putting in larger sheets and doing the flexiureteroscopy. So once we justify that large is doing damage, and we go back upon the large. I mean, this is food for thought. So therefore, this new concept has now come in, sheathless ureteroscopy. Don't put any sheath, just the ureteroscope. People do it just on the guide wire. You put in the ureteroscope. A little more difficult than going without the sheath, can damage the ureteroscope also. And the pressures in the pelvic calyceal system, the possibility of rise of pressure is higher. All those things are debated, but then science is, continuously there are questions asked, and there are people for and against a particular methodology of removal of stone. But these are issues against flexible ureteroscopy. The secondary procedure rate, as I say, in flexuretroscopy is 100% because every patient ends up in a double J stent, so he has to come in again. And if you're pre-stented, he comes in the OR or at least gets a procedure done for a second or a third time. Whereas in PCNL and UMP, it's a single procedure. You do it once and the patient goes home. Sometimes because of some complication, you need a secondary procedure, but that is very, very small compared to the flexuretroscopy secondary procedure. Now, this is the paper came out from Crow's, a global study, again, multiple investigators, and the conclusion was best results for flexuretroscopy. Best results after single session flexuretroscopy were obtained for stones less than 15 millimeters. So this is what the general consensus is. Don't try and extend it to more than 15 millimeters. Experts can do it. Experts are not an average urologist. So this is something which comes from, I would say that sharing of wisdom from experts who go on to say that 14, 15 millimeters would be the cutoff for flexuretroscopy. If I compare the stone-free rates of UMP versus flexi, the stone-free rates are better in UMP. You're removing the fragments. The cost is substantially less. Reusable equipments, the laser fiber can be reused. The instruments can be reused multiple times. The telescope is very fragile, but if properly handled, can give you easily 60, 70 procedures. The procedure time is 1/2 or even less compared to flexi. The learning curve is higher, and all that the learning curve needs is a good puncture, which as Indians, we are all good. And I keep using this slide when I step into the Western world, that we are a country with multiple states, and each state is the population of your country. Like Gujarat, from where I come from, is equal to the whole of South Africa, and Uttar Pradesh is Brazil, and you can see, you pick up any state, Tamil Nadu is Turkey roughly. So each state is having a population equal to that of that whole country. What it means thereby is we have a lot of material to hone our skills, and therefore a lot of good PCNL experts are there across the country. I mean, there are at least 100 people who can be considered absolutely proficient in their art of PCNL, in their art of puncture. They hardly need a second pass. Some of them do by ultrasonic guidance, some of them do by fluoroscopy guidance, but they are all good across the board. And this is another slide which I keep flashing. The population of India and China is more than the population of rest of the world almost. This was to give you an idea that the number of patients we have in India compared to smaller countries, for example, Netherlands here. So we do have a lot of material, and therefore we as a nation has contributed a lot to PCNL. And the only thing that I request the juniors is compile your data, do it very systematically, and publish in peer-reviewed journals. I'm coming to the end of my talk, and I have to put up some statements. Like when you do a bad puncture of PCNL, you may damage 5% of nephrons. But when you do a bad flexuretroscopy and endanger the ureter, 100% of the nephrons are at risk. That ureter is guarding 100% of the nephrons. And if you have messed up with that ureter, you have created a problem for all those 100% of nephrons. Therefore, UMP will continue to play an established, if not total, role in endoscopic stone treatment in future. And we have published in peer-reviewed journals. This is in the Journal of Video Urology, our technique of the video of Ultramini PCNL. This was the first paper of Ultramini PCNL published in 2013 in British Journal of Urology. 2013. This was the first paper on miniaturized PCNL, as we call it. This is a paper by a group of investigators, Martin Schonthaler from the University of Freiburg, and this group from the Royal London Hospital, and myself from here. Arkadiusz is a professor of urology with Martin Schanthaler, a very, very cerebral professor in Germany. So we published this Ultramini PCNL versus flexiureteroscopy, a matched analysis of treatment cost in patients with renal stones between 10 to 20 millimeter. And the cost of Ultramini PCNL is substantially lesser, which is extremely important in the Asian circuits. This was a paper published in the Journal of Urology coming out of America in the new techniques section. And we finally got the FDA approval in February 2016, Department of Health and Human Service, Food and Drugs Administration. This was the set which was tested by the company Scholli Ultramini Nephroscopy set. You may therefore market the device, and this came from the Office of Device Evaluation. So this is an FDA approved set. We have done a workshop in Harvard along with Brian Eisner in Mass General Hospital. We have done another workshop in the University of Miami, and UMP is now, it has entered the American continent as well, North America as well. So the future, I believe, for stones up till 1.5 to 2.5 is either UMP or flexiureteroscopy for smaller size stones, and larger stones, more complex stones, should be tackled by mini PCNL or conventional PCNL. And this is the algorithm. Upper calyx stones, if they are smaller stones, SWL. If the stone is larger, flexiureteroscopy up till 15, 18 millimeters. But beyond that, if the stone is very hard, UMP. If the stone is in the lower calyx, our first choice is always UMP. If the stone is in middle calyx or pelvis, for larger stones, it is UMP for us. For the smaller stones, we still believe ESWL is the way to go. So this is the algorithm we would follow.